So I'm going to start talking about a couple of fracture cases, and hopefully this will generate some good discussion. So first case here is a distal tibia fracture. It's a 63-year-old female, low energy mechanism. And we can see here on the AP and the lateral views, some of the kind of key findings here. Generally a pretty well-reduced tibio-talar joint. You can see that posterior spike moving cranially, and the extent of that is going to be part of our decision making. Looking at the fibula fracture, not widely displaced, but it's definitely present. We know that presence or absence of a fibula fracture in the distal tibia is not necessarily correlating with overall severity of the injury, but it's an important thing to recognize. And then obviously the most critical thing with these distal tibia fractures is going to be soft tissue management, how we do that, when we do that, and that's always part of the decision. So with an injury like this, I think you have so many different options. The majority of these are going to get some sort of axial imaging. Most of that's going to be CT scans. Whether you plan to do external fixation is always a critical decision. That can allow for a lot of restoration of length for anything that's dislocated or significantly shortened, can stabilize the soft tissue and try to preclude any ongoing injury. And then as far as timing for surgery, if there is a significant soft tissue injury, that can really help maintain your length and alignment so that when you return to the operating room for your definitive management, you're not fighting a bunch of shortened, scarred, and soft tissue. So when in doubt, span it out. In this case, we got a CT scan and a splint. We see a nicely placed splint with a good neutral ankle position on the sagittal reconstruction there. And on the axial view, it's a little bit tough to see, but if you look carefully, I think you can see that there's a non-displaced crack separating this into the typical three fragments of the pilon fracture or distal tibia fracture. And we've seen some good data showing the sort of typical fractures and where they happen. So we've got this anterolateral fragment, which appears to be following the fibula. We've got the typical medial fragment, in this case, very large without a central die punch piece. And then not displaced from that in this case, we see this posterolateral or Volkmann's triangle piece back here. So kind of a typical pattern, although atypical displacement or less displacement than is common. And on the sagittal, we can see that there's some posterior and cranial translation of the tibio-talar joint, although it seems to be moving relatively en masse. So we're not seeing a lot of articular impaction, at least at this cross section. So intraoperatively, the way this one was treated is some open reduction and independent lag screw fixation. And anytime you've got a fracture surface that you can compress, I know that Dr. Marichek is a big fan of compression of any fracture surface. So this is sort of letting lag screws be lag screws and let them do their thing. So we've got an anatomic reduction up here at the cranial spike on the lateral view. And we've got that lag screw going from that displaced posterior spike into the anterior tibial cortex that's intact. So that's acting at the apex of that fracture. And that's sort of the first major reduction that was done, and that drives that medial fragment and the posterior lateral fragment back into their anatomic location. And then once that's in place, this cannulated screw, which you can see on the central image here, running through the Chaput fragment attached to the anterior inferior tibiofibular ligament, excuse me. And that allows to compress that and reconstruct the syndesmotic stability, at least in the front of the syndesmosis. This screw here you can see is a lag screw in the fibula, and then a neutralization plate. So once you've got those lag screws doing their thing, we want to protect them. We want to give them the ability to do what they're good at and not ask them to do something they're bad at. So protect against rotation and translation and just allow them to compress. So here's a nice plate along the medial side, some short locking fixation into the distal part of the injury, some longer screws in the midsection, and then nice bicortical 3.5 millimeter screws approximately, well reduced on the lateral, on the AP. And then because the fibula fracture and some intraoperative stress exams showed instability of the syndesmosis, they've also got an interosseous screw here. We could probably talk for about 7 days on whether people would use a screw or flexible fixation these days, but I think we know that this is reliable and a really nicely reduced and stabilized injury. So here's some follow-up films. You can still sort of trace out some of the fracture lines, but a nicely reduced syndesmosis and nicely reduced tibio-talar joint, and I think a good example of how an accurate reduction and stable fixation can lead to a good result in these. Would you like me to keep going, Jeff, on another case?
Yeah, let's just do one more.
Perfect. All right, here's a little more typical pilon fracture.
Jeff, do you guys mind? James, do you mind if I just make a few comments? Because that was
I would love it.
That was a really
Please
great
do.
presentation, and while it's still fresh on everyone's mind, maybe we can just have a little discussion about it.
Please.
That was great. Thanks, man. That was really cool. So just a few comments on if you go back to your first batch of x-rays and then the
Injury?
CT scan, yeah, the CT scan actually shows it beautifully. So if you look at the image on the right, you see how shortened that is. That's probably 2 centimeters, I would think, at least. And that's the dirty little secret about pilon fractures, in my opinion, is that the thing that makes it hardest to fix these or reduce them is the shortening that happens. Like the articular reduction is, let's be honest, it's not that hard really. It's like puzzle pieces. It's hard if there's marginal impaction and you're missing pieces of joint and you have holes and defects, but by and large, you just kind of put them all together. But the shortening is what I struggle with. And the longer it sits like that, the worse it is. So my point is, when y'all X-fix these, man, you really got to hog on it and get that straightened out as much as possible. And that's why I hate delta frames, because I don't believe you can control the distal end of the tibia through the calcaneus alone. So I always put a pin in the talar neck, right smack in the middle of the talar neck medially. That's super hard, dense bone. It can accommodate a 5.0 millimeter pen pretty easily. And then you can build that out to whatever you put, transcalcaneal or a calcaneal pin or something like that. And then you have dramatically more control over the distal end of the tibia, and you can pull pretty good pressure on that and at least make up half of that difference. You're never going to get it all the way down, because you're going to get some stretching through the ligaments and stuff like that, but you'll help yourself tremendously. And the fact that you got such a gorgeous reduction on that with your screw, I don't know if people realize this, was posterior to anterior. So I want to ask you how you did that, because obviously your incision wasn't posterior. But the fact that you got such a good reduction tells me that either this was really fairly fresh, the fracture, or you're super strong, or you have a technique for making that thing slide down. So I guess my question for you is, one, what's your reduction technique for shortening in a pilon fracture? And then two, that posterior to anterior screw, I mean, it's like spot on. You nailed that reduction and you got a nice lag screw across it. But how did you do that? Did you have the foot up in the air like this in the OR? Did you do the patient lateral? Because that's a tricky screw. That's not something everybody could do, I don't think. And it's not even a cannulated screw. It's a solid screw. So that means you pre-drilled it and popped it in there.
So those are, I think, every discussion point that I wanted to bring up, you brought up. So thank you. So first off, this is the full disclosures. This is a case that everybody can look through the details, because this is on OrthoBullets and it's not my case. So I'd like to thank OrthoBullets and the author for sharing this and making it available to us. But I think it's great because now everyone can go back and not just say, what was it look like again? But when I went through the details of it, this surgeon chose a medial plate, which for me is an anxiety provoking implant because of how stiff they need to be and how little soft tissue there is there. But because of that, you know that the incision has to be at least somewhat medially based, or at least a dissection has to be medially based. And that raises a whole other set of questions and often another set of eyebrows. So for this, you can, as we've sort of skipped around, that there is no external fixer. So this was fixed acutely. And I think that's part of it, is recognizing the mechanism, the energy level of the injury, and then the soft tissue injury. So that if you think that it is something that is questionable, obviously if they're developing fracture blisters, or if you just don't feel comfortable with the amount of swelling and soft tissue injury they have based on how much dissection and operating time you might need, then the safe answer, the conservative answer, the confident answer that is not taking risks for your patient is going to be spanning it out to length. And Tony, what you said about getting it reduced in the X-fix, I cannot echo that any more strongly, is that you've got to, whenever you place an X-fix, it's not just 2 pins in a bar and there you're good. It's you use the external fixator to achieve a reduction. And that's the most important thing, is you got to get it out to length in the X-fix. You got to get it reduced in the X-fix. And when I see people put 2 pins in the tibia and connect them with one of those little bullhorn connectors, and then a pin across the calc, and then they just kind of pull and pray, that's the method that just never achieves a reduction, because you have no ability to control things in a logical, stepwise manner. So I like to sort of get my length with my first set of implants in an X-fix, and then slowly build in my reduction and my stability by adding more bars and clamps depending on what sort of forces they need to reduce it. As far as lag screw placement, yeah, that was an open reduction. If I was going to do this in that way, I would have a large Weber clamp, so I could have a stab wound in the right on the crest of the tibia, really, just sort of direct anterior anteromedial. And then I would have it outside the skin, and I would have it pushing on the spike, and I'd probably have a drill hole or otherwise some sort of direct control of the posterior portion of the joint, and I'd stick a large shoulder hook or other sort of device in order to control that, and I'd be pulling down on the joint until I get it all the way out to length, and I use my Weber clamp in order to squeeze it together and dial that spike right into the apex. And I think this, with a clamp and then followed by a lag screw, would be a pretty stable reduction in the back, because you've got large surfaces, a nice apical point that you can get things to really become stable.
I love your comment about the anxiety of the medial plate, because the other thing I was going to ask you is, why not an anterolateral plate for this one, especially when there's a Chaput's tubercle fracture? That's usually the direction that I lean in. And I lean a lot more towards fragment specific fixation in pilon fractures now, because I can't stand those big fat plates, especially the medial ones, for a lot of reasons. One, the stiffness, and two, just soft tissue doesn't really respect it that well. So that was cool that you made that comment. The other thing, well, now that's all I got to say about that.
Yeah. All right, so let's actually, Dr. Rohr, if you want to present at least one of your cases here, in the interest of time, we're about halfway through this portion. So thanks, James. While you're pulling that up, telling you that the length sentiment, I could not echo more. I teach our residents, if you see the dime sign of the distal fibula, then you got to break that and keep pulling, and then you're far enough. So.
Yeah, if you think you've got it out to length, add more. If you think you might be a little bit long, you're good.
Yeah. The other thing about the external fixator is that it's serving two purposes. One is to get the bone out to length, but it's also supposed to be a soft tissue rester. And if you don't have a really stable construct, again, why I hate the delta frame, you're not resting the tissue, because the calcaneus will spin around that pin pretty easily. And so the foot is flopping around and the ankle's flopping around. And I mean, you'll see people in delta frames for 3 weeks still with fracture blisters. And I think that's the reason why that happens. And the other comment that I would make is you talked about how that case got done right away. And that is something that I think everyone has kind of come full circle on. There are some pilons that you can fix right away. Obviously, if it's got fracture blisters or if it's open, it's not a fixer right awayer, but low energy ones, man, sometimes it's a hell of a lot easier. Like that case would have been a bear if it was 10 days old. As short as it was, even the fibula would have been a hard reduction.